Okay, well, I think we'll make a start now, and other people will come into the meeting as we go along. But we'll welcome everyone to Paediatric Teaching for today. I wanted to talk today about epilepsy, and the last couple of weeks we've talked about very clinical topics. We've had some clinical case discussions and things, and today I wanted to talk about epilepsy because I think these are fundamental things that paediatricians need to know about. And we all look after a number of children that have epilepsy, and they have a lot of comorbidities, and we see them in our hospitals quite often. So I wanted to talk today about some mostly theoretical aspects of epilepsy, and about how I'll just admit a few more people, how we can understand different aspects of epilepsy and look after these patients in a better way. All right, so the talk today is not going to be so much case presentations or anything, but I'm going to be talking about epilepsy, and I'll try to get across some important concepts. I think about epilepsy. Often we sort of think of all epilepsy as being the same, but there are many different types and different ways of managing them and different medications that can be used. So I'll talk, this is the sort of outline of the talk. I'll talk a bit about I'll just wait till a couple of people come in. This is the outline of the talk. I'll be talking about excuse me, I'll just have to admit a few more people who've come in now. I'll try to cover what is these days an accepted definition of epilepsy. I'll say a little bit about the epidemiology of epilepsy in developing countries. It's a bit different to other countries. I'll say something about the terminology, because we often hear about different types of epilepsy, and I think it's important that we are clear about the terminology. Something about the classification of epilepsy and the types of seizures. There are certain patterns of seizures that you can notice in a child, and sometimes they fit a certain pattern, and that pattern might be associated with a certain prognosis or outlook. And sometimes different patterns of seizures or different types of seizures can be better treated with one drug compared with another drug. We'll say something about the importance of comorbidities, because in children in Papua New Guinea, comorbidities with epilepsy are very common. And we'll say something about the causes of epilepsy. I'll mention about these epilepsy syndromes, these patterns of epilepsy, and we'll spend a bit of time talking about different anti-epileptic drugs. I mean, for many of us, there's not a small number of drugs that are available, but it's important to know how those drugs, the mechanism of action, and what types of epilepsy they can treat best. So that's the outline of the talk today. So welcome everyone. We should have a definition of epilepsy, because not every child who has a fit isn't epilepsy, and the accepted sort of international definition these days is that the child should have at least 2 unprovoked seizures. I'll explain what unprovoked means, but at least 2 unprovoked seizures more than 24 hours apart. So if they have 2 seizures within a period of 8 hours, that's not epilepsy. It's less likely to be epilepsy, but it's a child who has a seizure one day and then a week or 2 later has another seizure. And these are, as I said, unprovoked seizures. They're not febrile convulsions. They're not in a child who's got meningitis, acute meningitis, or acute malaria, or trauma, or any other form of acute brain injury. Although these children, if they have meningitis, of course, can develop epilepsy. They can go on, and after their infection or their initial injury is treated, they can go on to develop epilepsy. But when they come in with acute seizures related to meningitis or acute seizures related to a febrile convulsion, we don't call that epilepsy. That's just a febrile convulsion related to their underlying infection. So that's what unprovoked means. They're not provoked by any other illness. And that's sort of generally the case. Although children who've got epilepsy, of course, they can have their seizures provoked by, if a child has, with epilepsy, an older child has a urinary tract infection, then they can have worsening seizures, or some seizures can be provoked by intercurrent infections if a child has them. So it's a little bit complex, but you just need to know the generally accepted definition. I often teach people that you need to appreciate what are seizures and what are not. I mean, many times children have a movement disorder and it won't be it's not seizures. So there are many children with, say, Sydenham's chorea or other forms of movement disorder that are not seizures. And to recognize seizures, then they should, the movement should involve the same muscle groups repetitively contracting. So if you look at the arms or the legs of the patient, you can see that it's the same muscle groups that are repetitively contracting, and they're not suppressible by tactile pressure, which just means I always at the bedside try to, if it's uncertain whether the patient's actually having a seizure, then just try to gently press on the limb and see if it settles the patient and see if they stop seizing. Because if it's truly seizures, then they'll continue to seize underneath that gentle tactile pressure that you put on it. But if it's something else, if it's just that they've got some cerebral irritation and they've got some muscle spasms, then often that will settle. So there's some definitions. I want to cover the most common cause of seizures is not epilepsy, but it's febrile convulsions. And just to give you some idea about the frequency of febrile convulsions, these are some things that I generally tell parents, or some of these things I generally tell parents when children have had a febrile convulsion. That I usually tell them about 5%. So 5% of all children will have one febrile convulsion up to the age of 7 years. So when you're telling parents that, you're explaining just how common this problem is, and for them not to be too worried about it if all they've had is a febrile convulsion. Febrile convulsions tend to run in families, so they don't always run in families, but they tend to be more common within families. And so about a quarter of all children who have a febrile convulsion will have a family history of a febrile convulsion. So more than what you'd expect, which is somewhere between 3 and 7% or 5%. And 4% of children who have a febrile convulsion have a family history of epilepsy. So there is a link between epilepsy and febrile convulsions, and there's certainly a link between febrile convulsions in parents and febrile convulsions in their children. About 20% of them will have a febrile convulsion that's said to be complex, and that is it either lasts for longer than 10 minutes or it's localized, not generalized, or maybe asymmetrical. And so we call that a complex febrile convulsion. It still can be benign, just like other febrile convulsions. The child recovers and there's no problems, but children who've had prolonged or more complex febrile convulsions are a bit more likely to have ongoing seizures. About a third of all children who have febrile convulsions, so that's very common, a third of those children will go on to have another febrile convulsion. So that means 2/3 don't have that. And I generally tell parents this, that about 5% of all children, all kids everywhere, will have a febrile convulsion sometime up until they're 7 years of age, and about a third of them will go on and have another febrile convulsion. But that means 2/3 of them won't. All right, and it just means parents need to be a bit more vigilant when their child has a fever. But you can also reassure them that febrile convulsions are very benign, that if it's just a febrile convulsion, then the child will have a normal cognitive and neurological outcome. They won't have any neurological injury from it if it's just a febrile convulsion. Usually, because febrile convulsions are benign, because they usually stop by themselves, then you don't need to give any medications. But sometimes for some parents, if the child's having frequent febrile convulsions, then we'll give them some midazolam to take home, and the parents can learn how to give intranasal midazolam, or sometimes rectal diazepam. Now, these treatments are usually, if a child comes in with a prolonged or atypical or complex febrile convulsion and it's going for a long time, then I usually give them some rectal diazepam. That will usually stop the febrile convulsion. Parents often think they're not doing the right thing if their child develops a fever and has a seizure, but usually the seizure occurs at the time the fever's going up. So there's no real way that the parents can actually anticipate that their child was going to have a febrile seizure. So that's important that parents know too. So the things that I tell them, 5% of all children will have a febrile convulsion. I always tell them that my oldest daughter had a febrile convulsion, so very common. 5% of children have one. About a quarter of them have a family history, and about a third go on and have another febrile convulsion. So the main thing you need to reassure parents is that they are benign problems. They're not, they don't not associated with a serious neurological outcome. Right, so that's febrile convulsions. I wanted to get that out of the way because they're different to seizures and different to epilepsy. And I wanted to explain a bit about epilepsy and its complexity. So it's been estimated that somewhere between, in most countries, somewhere between 1% and sometimes up to 3 or even more % of all children will have epilepsy. So maybe if we, think about it, somewhere around about 4% of all children will have epilepsy particularly in low-income rural countries. Then epilepsy is more common, and I'll explain why epilepsy is more common in those environments. I won't go through the incidence, but there are various estimates of incidence. But if you think about it, somewhere between 1 and 4% of all children will have epilepsy. So it's quite a common problem. I wanted to explain some things about different types of epilepsy. And so I think it's useful to just divide them into focal seizures and generalized seizures. And the reason why that's important is because there are different medications that work better in focal seizures and other medications that work better in generalized seizures. And sometimes focal seizures become generalized seizures, and sometimes generalized seizures just start as being an acute generalized seizure. There's another way you can describe seizures too. They're either focal or generalized, and they can either be with a child alert and awake or less conscious, unconscious. And most seizures, of course, are in children who are poorly conscious. They've lost consciousness or lost awareness. But sometimes you can have a focal motor seizure with the child fully awake, and that's another type of seizure. So focal or generalized, awake or unconscious, and sometimes, well, I'll just explain some of the other ones, but remember that focal or generalized, awake or less conscious. This is the international classification for epilepsy, and it really follows what I've just said, is that there are focal seizures and there are generalized seizures, and usually they're described as to how they start. So a focal seizure that becomes generalized is still a focal seizure, because what most likely is that there's some stimulation within a focal area of the brain that sets off the electrical activity that leads to a seizure. But it starts with a focal seizure first, with focal motor twitching, and that may or may not stay focal, or it might become generalized. So don't worry too much about the complexity of this classification, just know focal and generalized. And then some, of course, we don't know what the onset is, and we describe them as either tonic, clonic, or other motor. Sometimes that's just a myoclonic seizure. And then there are some seizures where you just simply have an absence of consciousness. And so instead of having any motor twitching, then the child just has an absence of consciousness, and they're called absence seizures, where the child may be alert, but then suddenly lose consciousness it's usually for a few seconds, and then come back to, I'll just admit some people now, and then come back to consciousness after a few seconds. So just know focal and generalized, and aware and alert or impaired consciousness or impaired awareness. The causes of epilepsy, most causes of epilepsy are what we call idiopathic, which just means we don't really know the cause, but increasingly we're understanding that most of the idiopathic types of epilepsies, what we used to just consider epilepsy of unknown origin, are genetic in nature. And as more and more genetic testing is being done in patients with epilepsy in different countries, it's being found that most of the cases of so-called idiopathic epilepsy or epilepsy of unknown origin is either polygenetic or monogenic. What that means is either one gene abnormal or multiple genes abnormal, and the child may otherwise be perfectly neurologically normal, but they may have one genetic abnormality that leads them to have epilepsy. And so years ago, of course, we didn't know the causes of most of the types of epilepsy, but now we know that more often they're genetic in nature. I think it's important the way we have a way to explain that to families, and it doesn't. We should explain it in ways that don't make them feel that they're somehow to blame, that they've given epilepsy to their child or the mother gave it to the child. That's really important that that's explained. That, and in some ways we're better off just saying, well, for many children with epilepsy, we don't know the cause. There are some genetics involved, but we don't actually know the cause, and that would be the truth. Of course, in some countries, like particularly lower income countries, then secondary types of epilepsy are more common. So there are many types of epilepsy that follow infections or follow ischemia or vascular injuries to the brain or following trauma or related to tumors or some sort of genetic malformation of the brain. So these are the common secondary causes of epilepsy. So infection, ischemia from a stroke, for example, or vascular injury like a stroke. I'm looking after a child at the moment who's had a stroke from bacterial meningitis and sinusitis. So he's had a stroke and he's got epilepsy. And then trauma, tumors. So you need to have a good understanding of the secondary causes. And when you see a child with epilepsy, try to understand whether or not they've got idiopathic epilepsy, that is epilepsy of uncertain origin, or whether they might have some other underlying cause. This is important because to fully understand the type of epilepsy a child has, it's really important that we go into the history of what was the original cause of the epilepsy. Okay, there are some, I won't go through these too much today, but there are some patterns of epilepsy that we recognize in children, and some of them are quite, it's important if we can to try to recognize these patterns, because some of them are associated with a very good outcome, and you can then be quite reassuring to parents that this type of epilepsy is common, that it's benign, it will get better, and the child will do well. And then there are other types of epilepsy where children have a much worse outcome, and you can tell even from the first year of life, when a child presents with some types of epilepsy, that they're going to go on and have ongoing difficult to control seizures. So I'll just go through some of these types of epilepsy. These are all what we call idiopathic epilepsy, but some of them have a genetic basis. I'll just go through them briefly. The first one is this condition called benign rolandic epilepsy. It's benign rolandic epilepsy of childhood. That's the name, and it's one of the better epilepsies to have, I would say. That, and the way you can recognize is that the children usually have what we call focal seizures, and they're usually at night, often in the early hours of the morning, like 4 or 5 a.m. And they often start with a sort of a tingling feeling in the mouth, or the parents notice that the child has grunting noises or dribbling. And sometimes that then goes a focal seizure that becomes generalized. That's the typical thing, a focal seizure that becomes generalized in the early hours of the morning. And usually these seizures they start somewhere between 3 and 10 years of age. It's one of the more common forms of epilepsy, and it's good to be able to try to identify this type of epilepsy, because these children, generally speaking, will have a good outcome. Their seizures will resolve when they get to be teenagers, and the parents can be relatively reassured. And so this is benign rolandic epilepsy. And I suppose the key features are the age of onset, the fact that the child has the time of day the child has seizures, almost, not always, but almost always in the early hours of the morning or at night, and that they start with a focal seizure that becomes generalized usually. And sometimes we don't even treat these seizures. Sometimes that if a child has 1 or 2, then we don't treat them. But if they're becoming more frequent, then we would normally use an anticonvulsant treatment to treat these children. I think it's quite important if a child has more than 2 or 3 seizures that they go on to an anticonvulsant because of the some children who have seizures overnight can have periods where they have vomiting or aspiration, or they have airway obstruction. So I think it's quite important that these children get. Oh, sorry. Yeah. Okay. Sorry. I think it's quite important that these children get anticonvulsant medications if they've had 2 or 3 such seizures. But try to recognise this type of pathology. Another child characteristic pattern of seizures that I think we can recognise sometimes is what I described before about absence seizures, where children have they're otherwise okay, and then they'll lose consciousness. They'll just become vacant. They're not alert. They are not attentive, and they'll just lose consciousness, often for only a few seconds, and sometimes it goes unnoticed by people around them. But the child themselves will feel quite strange because they've missed out on a period of interaction. Sometimes the child falls down, of course, but often they don't. They might be sitting there in the classroom and their eyelids flutter and they just become unable to respond to what's happening around them. And they lose awareness of what's happening. And that's called absence seizures. It's a type of epilepsy that sometimes children grow out of childhood absence epilepsy, and sometimes they're associated with other types of seizures like myoclonic seizures or generalized seizures. But the absence seizures are quite common and useful to diagnose. I mean, again, sometimes these children don't need anticonvulsant medications, but if it's becoming a real problem and they're having frequent seizures, then I generally treat them with anticonvulsant medications. They usually respond quite well to medications, and you can make their life much better by having them seizure free. The third type of epilepsy syndrome that I wanted to discuss. So these first two types, benign rolandic epilepsy and absence seizures, have quite a good outcome. They often resolve. And the third type, juvenile myoclonic seizures or myoclonic epilepsy, also has quite a good outcome. These children have seizures when they're a bit older. So I'll just let somebody, the seizures typically start when they're teenagers or adolescents, and they may have myoclonic seizures, which are just upper limb muscle jerks, often at the upper body, not always, but sometimes just the upper body. And sometimes children with juvenile myoclonic epilepsy will have tonic-clonic seizures as well, and sometimes they'll have absence seizures. So they may have a mixture of seizure types. And when you're taking a history for a child who you think has epilepsy, it's important for us to know to try to take the history of the seizure type and whether or not the child is conscious throughout or loses consciousness, if they have a generalized seizure or if it's focal, if it looks like it's myoclonic, if they have any periods of apnea or breathing obstruction. Those sorts of things are important to know. Sometimes, again, like benign rolandic epilepsy, juvenile myoclonic epilepsy often occurs just around about the time a child's waking from sleep in the morning. Usually they become less severe in adult life. And so many children with myoclonic epilepsy, by the time they're young adults, their epilepsy is resolved. And these children, adolescents, typically they can have triggered seizures. Their seizures can, if they stay up late at night and watch television overnight, or they start drinking alcohol, or anything that might trigger some stress response in these kids, can lead to seizures. So it's important when you're looking after an adolescent who's got who you think has myoclonic epilepsy or any form of epilepsy, to advise them again. You make sure they get enough sleep. It's very important. It's as important that they get enough sleep as what it is that they stay on their medications. So you need to warn them against drinking alcohol and having missing out on too much sleep and eating normally. These are all things that can help seizure control as well. So we talked about benign rolandic epilepsy, we've talked about childhood absence epilepsy, and we talked about juvenile myoclonic epilepsy. And then the last seizure pattern, if you like, that I wanted to just discuss is this pattern called infantile spasms. And this, unlike the other three that I've talked about, is not a good epilepsy to have. And most children that have infantile spasms, they have seizures that are quite difficult to control. They often have frequent seizures and multiple seizures in any day. Infantile spasms may be genetic in origin, and sometimes they're triggered by some other illness like post-meningitis or post-stroke. And yeah, typically in these children, they've had quite a severe brain injury before the age of 6 months. So I'm sure we've all seen children with this pattern of seizures. And sometimes these children can have 10 or even 100 sort of spasms, within a day. They have clusters of seizures typically. We often try lots of different anticonvulsant medications in these children, and they sometimes are partially effective and not always. I mean, the anticonvulsant medications often used a Phenobarbitone, but sometimes steroids can have a beneficial effect on children who've got so-called West syndrome or infantile spasms, and that's a treatment for children who've got intractable or difficult to control seizures. There is a syndrome that some of them go on to develop, which is called Lennox-Gastaut syndrome, and that is really just another epilepsy syndrome that occurs in older children that have multiple different seizure types. And so I think most of us have seen a child who's got multiple different seizure types with developmental disability in older childhood, and they often have this thing called Lennox-Gastaut syndrome. And they sometimes start with a brain injury in the first 6 months of life that develops into multiple seizure types, and then later on they go on to develop Lennox-Gastaut syndrome, which is just ongoing epilepsy. Okay, so we've talked, I guess, about the forms of idiopathic epilepsy, and I mentioned 4 different types. So benign rolandic epilepsy, childhood absence epilepsy, and myoclonic epilepsy, and then a more, I would say, more serious form they're all serious, but a more concerning form of epilepsy called infantile spasms or West syndrome. And then sometimes, as I said, they go on to develop Lennox-Gastaut syndrome. So it's not always possible to characterize a child's epilepsy, but sometimes it is. You can put them into certain categories, and that can help us explain to families what's likely to happen and what the prognosis is. And another way to really understand the prognosis of epilepsy is to treat it and see if it responds quickly. And for children who have anti-convulsant responsive epilepsy, that is, you make them seizure-free in a short period of time, generally they'll go on to have a prolonged period of being seizure-free. Their development will be normal, and in a year or 2 or 3, you'll be able to wean them off their anti-convulsant medications. But when children have quite difficult to control epilepsy, or have multiple different types of epilepsy, or one drug doesn't work and you need to use 2 or change drugs, then their prognosis is likely to be more difficult. So I wanted to now explain a bit about some anticonvulsant medications. And remember I said there's value in trying to understand the types of epilepsy, and particularly focal versus generalized. And one of the most important things about trying to distinguish between focal and generalized seizures is that different medications work a bit better in some and a bit better in the other. And particularly for focal seizures, carbamazepine, or sometimes called Tegretol, but carbamazepine is generally a very effective drug for focal seizures. Other medications, phenotone, Phenobarbitone, they work okay also in children that have got focal seizures, but perhaps not as well as what carbamazepine does. And then generalized seizures, there are some medications that work better in generalized seizures, and the drug that seems to work the best in generalized seizures is sodium valproate or valproic acid. I'll just admit someone else. Sodium valproate probably is the most effective drug for most children with generalized epilepsy, but it's not always available. Um, and usually we fall back on Phenobarbitone, which is also quite good for generalized seizures. And then another new drug called levetiracetam, or that's also has another name called Keppra. That's also a very good drug for generalized seizures. And I put quite a number of my patients on either valproic acid, sodium valproate, or levetiracetam because they generally have less side effects than Phenobarbitone. But Phenobarbitone is an effective drug against most generalized epilepsy. But the problem with it is that it tends to cause drowsiness and can affect children's development. So if you have it available and if there's a good supply of sodium valproate, or if you can get Keppra, that's an even better drug. But so it's useful to know, I think, the different types of drugs and which ones are more effective in generalized epilepsy and which ones are more effective in focal epilepsy. So I wanted to go in a little bit of detail about the anti-epileptic drugs that are commonly used, so you'll know a bit more about them. And I think it's useful for us to know something about the mechanism of action, like how do they work? How do these medications work? Something I've already said about the types of seizures they most commonly treat. And then I'm going to say a little bit about the effect on liver enzymes, because when we're using different drugs, it's important to know whether they the effect they have on the liver enzymes, because when you're using more than one drug, then sometimes they can be inducers of liver enzymes, and that can mean that the liver enzymes that break down other drugs can mean that the other drugs levels are lower. And that's particularly an issue if you've got a child, say, on TB medications or HIV medications, and they're also on anticonvulsants for some of the medications. I'll explain them in a little while. So the three things I wanted to explain were something about the mechanism of action, something about the type of seizure they mostly treat, and then something about the effect on liver enzymes. Now, this is a complex slide. You don't need to know this. I'll send the slide around, but it gives you some idea of what we know about the mechanism of action of these drugs. And if you think about a nerve ending or a neuron, then remember what makes the action potential travel through the nerve, and what makes the action potential stimulate another nerve is sodium channels. And these channels allow the sodium to get in. And some children who have epilepsy have abnormalities of the sodium channels in their neurons. And some of the anti-epileptic drugs, they work by blocking the sodium channels. So they make the brain a bit quieter because there's not quite so much influx of sodium into the neurons. And so the two drugs that we know about that work on sodium channel blockade are phenytoin and carbamazepine. So sometimes called Dilantin, phenytoin, and carbamazepine. The next type of mechanism of action I wanted to explain was about GABA, and that's gamma aminobutyric acid. You don't need to know about that, but GABA is one of the excitatory neurotransmitters. So we've got neurotransmitters in our brain that make us more excited or stimulate the brain, and some neurotransmitters that dampen it down. And there are GABA is a stimulatory neurotransmitter, and when you've got epilepsy, sometimes Phenobarbitone and benzodiazepines like diazepam or midazolam or lorazepam, they function by enhancing GABA. Now, sorry, GABA is a suppressive neurotransmitter, so that if you've got GABA around, the brain will have less neuronal transmission, and then you've got less seizures. So phenobarbitone, the main thing is phenobarbitone and sodium valproate and benzodiazepines, they work by enhancing this neurotransmitter that keeps the brain a little bit quieter. Then there's another anticonvulsant that I'm sure some of you have seen, called acetazolamide, or Diamox, and that's a good anticonvulsant sometimes in some children, and especially if you've got a child who's got TB, meningitis, and hydrocephalus, then that's a very good anticonvulsant to use, because it can reduce the amount of CSF production as well. So sometimes we use acetazolamide to reduce CSF production. Then there are other drugs that we don't quite know how they act, like levetiracetam, this Keppra drug. It's a relatively new drug. It's only been around sort of 5 or 10 years, and we don't quite know how it works, but it seems to work very well without much in the way of side effects. And so that's why it's a useful drug. So if you just know that sodium channel inhibition, GABA enhancement, and sometimes carbonic anhydrase inhibition are the mechanisms of action of the commonly used drugs. So phenytoin, carbamazepine, phenobarbital, benzodiazepines, sodium valproate, acetazolamide, rarely used, but sometimes useful, and this new drug called Keppra, which is, I think, quite a good drug. I have many patients on that. So I'll just go through each of the drugs. Mostly, I won't talk about the mechanism of action, but we just need to know something about the side effects of them, I think. And when we put a patient on a medication, we need to explain something about the side effects to families. And it's always a balance between getting their seizures under control and the effects on their development and conscious level. So the side effects for phenobarbital are usually in older children, particularly difficulty concentrating in school, sometimes mood changes or depression, and sometimes it have a paradoxical effect where a child becomes more hyperactive. So phenobarbital is very good for generalized seizures, but remember I said sodium valproate is better. So if you've got that drug, I will usually use that drug. Phenobarbitone can also be used for focal seizures, but carbamazepine is better. So there are better drugs for both focal seizures and generalized seizures if they're available. Now, phenobarbital, as well as causing sort of some problems with sedation and delayed development, are potent inducers of these liver enzymes. And so we just need to know that whenever we put a patient on phenobarbital, it's relatively safe, but if you're using other drugs, then sometimes those other drugs, the blood levels will be quite low because the enzymes in the liver are induced, which means that there's more of them. So more of these cytochrome P450 enzymes get activated when you're on phenobarbital. It doesn't hurt the child at all, but we just need to know that if we're using some other a drug that is metabolized by the liver. So it's GABA enhancing. It's good for generalized seizures, but valproate is better. It's okay for focal seizures, but carbamazepine is better, and it causes some difficulties with development. That's the main thing about phenobarbital. Phenytoin is another drug we use quite a lot. It's a sodium channel inhibitor. Remember, phenobarbital is a GABA enhancer, and phenytoin is a sodium channel inhibitor. It's useful for either focal or generalized seizures, but remember, there are better drugs than phenytoin. The side effects that the children I have on phenytoin often want to be off it. They don't want to be on it too much because it causes a lot of gum hypertrophy, and children after some months or years don't particularly like that. All anticonvulsant medications have an effect on bone density, and this is something else that's important to know. So if you've got a child with epilepsy, then often many of the anticonvulsant medications lead to osteopenia. And this is something that maybe we don't always think about in our patients with epilepsy, but we should think about that because if they're on long-term anticonvulsant medication, they're likely to end up with fairly brittle bones. And so I always try to make sure they have adequate supplementation of vitamin D. Otherwise, they'll get brittle bones. Phenytoin can also be neurotoxic. It can cause neurological abnormality. So if you see a child on phenytoin and they've come in with a neurological deterioration, you should always think it could be the drugs. It could be the drugs causing this. Now, phenytoin, like Phenobarbitone, is also an inducer of these cytochrome P450 enzymes. And so, again, if you've got a patient on other medications that are metabolized by the liver, then we need to be aware that the levels of those drugs might be lower. Carbomezapine, remember I said, was very good for focal epilepsy, and it's probably the best drug for focal epilepsy. It's quite a safe drug as well, but it sometimes has some side effects like nausea and vomiting and diarrhea, and particularly if a child's on a dose that's too high. Sometimes it can cause bone marrow suppression, and so you need to, I always, once every 6 months or so, look at the full blood count of a child who's on carbamazepine to make sure they're not getting leukopenia or anemia. And they're also inducers of cytochrome P450 enzymes. So it stimulates the liver enzymes to be more, and therefore that they'll metabolize other drugs. Remember, so we've got sodium channel inhibition with carbamazepine, and we've got GABA enhancement with Phenobarbitone. The reason why it's useful to have some idea of the different mechanisms of action is if you have a child who's on, let's say a child's on phenytoin, you know that's a sodium channel inhibitor. So if their epilepsy wasn't well controlled with phenytoin, then you wouldn't add carbamazepine because that's doing the same thing. You might add a different drug that has a different mechanism of action. That's the reason why it can be useful to know the mechanism of action of different anticonvulsants. If you want to add another drug, then it's better to add a different type of drug, a different class of drugs. The last one I think I'll talk about is sodium valproate. I've mentioned that before. I think it's a very useful drug, sodium valproate. It's a GABA enhancer, a bit like Phenobarbitone, and it is the best drug for generalized epilepsy. Again, Phenobarbitone is good, but sodium valproate is better. It does have some side effects, and the main one is that you need to make sure that children, I always avoid other hepatotoxic drugs. So if I've got a child who's got is on TB treatment, for example, then I don't have them on rifampicin, isoniazid, and sodium valproate, just because they're three potentially liver toxic drugs, and you want to try to avoid that. Liver toxicity is rare. It happens in less than 1% of patients, and pancreatitis also can occur. So if you see a child who becomes jaundiced or has abdominal pain or vomiting, then you've got to think maybe they've got a drug reaction to sodium valproate. They might have pancreatitis, inflammation of the pancreas, or they might have liver inflammation. So it's just important to know that's the one thing that valproic acid or sodium valproate, sometimes called epilim, that will have. Unlike the other drugs I've mentioned, carbamazepine, phenytoin, and Phenobarbitone, sodium valproate's an inhibitor of enzymes. And so that means that sodium valproate will inhibit the cytochrome P450 enzymes. And if you have a patient who's on some other medication that is metabolized by the liver, then sometimes you'll need to be on a higher dose of those enzymes of that drug if that drug's metabolized to an active drug, and sometimes it'll cause toxicity of that other drug. So zidovudine, for example, when patients are on AZT, then they need a dose reduction because AZT is metabolized by the cytochrome P450 enzymes, and if they're inhibited, then that means that that you need to use a lower dose. Otherwise, your AZT levels will be will go very high. these are some of the side effects of anticonvulsant drugs, and these many different types of anticonvulsants. A number of different types of. I'm sorry, kid. Sammy, could you mute your device, please? Thanks. There are some side effects that we often don't worry about. We sort of think they're not important, but for the children themselves, sometimes they don't like having the gum hypertrophy from phenotone or dilantin, but it also occurs with other drugs, Phenobarbitone, sodium valproate. They can also all cause gum hypertrophy. And then some drugs cause rashes. So if you see a child who's on an anticonvulsant and they've got a rash, then you got to think it may well be the anticonvulsant. It doesn't mean you have to stop the anticonvulsants if their seizures are well controlled, but you might want to change their anticonvulsants. But there are many different rashes that can occur with anticonvulsants. So I said that we'd talk a bit about liver action of different drugs, and just to know that there are some anticonvulsant drugs that are inducers of cytochrome P450 enzymes, so carbamazepine, phenytoin, phenobarbitone, and rifampicin, the TB drug, not an anticonvulsant, but that's also an inducer. And there are some anticonvulsants that are inhibitors, so sodium valproate is an inhibitor, as is isoniazid. So the problem with inducers of cytochrome P450 enzymes is that sometimes the metabolism of these drugs will actually mean that the drug level will be lower, and that will reduce the effectiveness of other medicines because they're being metabolized much quicker. And with inhibitors, sometimes you'll get toxicity because the medication doesn't get metabolized, and then the drug level increases. So you need to adjust the doses depending on whether a patient's on, if they're on medications that are also metabolized by the liver. What's important to tell parents, I think, is that most children with epilepsy can achieve seizure freedom with medical treatment, and about 70%. So 30% of children will have some drug-resistant epilepsy, and that means that if they're resistant to one medication, they can be changed to another one, or they can have a second one added. What I usually do is start them on one medication, the most ideal medication for them, and then you increase it to the maximum dose as long as there aren't any side effects. And if their epilepsy is well controlled on that maximum dose, if they don't have any seizures on the starting dose, then I leave them on the starting dose. If they're still having seizures, then I'd increase the dose to the maximum dose, as long as they're not having side effects. But if after you reach the maximum dose, if they're still having seizures, then it's best to start another anti-epileptic drug that's got a different mechanism of action. So if you've been on a sodium channel blocker, then start them on a GABA enhancer, for example. That's usually the way to do it. And then after they're started on the second drug, then if you get seizure control, then withdraw the first one so that they remain on one drug. It's important not to have children on too many drugs. And I see a number of children that are on sort of 3 or 4 different drugs, and that's always prone to lots of errors. So it's much better if a child can be controlled on one drug or 2 at maximum, I think. Parents often want to know what the outcome is for their children. And generally speaking, for most children with epilepsy, their outcome is very good. 70% will have good seizure control, but there is an increased risk of mortality, and that is it's substantial for many children, and some of that mortality relates to environmental risks. So you need to if you've got a child who's got epilepsy, you need to be educating parents about certain things that they should and shouldn't do. I mean, it's really important to avoid environmental risks, and many children with epilepsy have burns, or they have drowning or falls and injure themselves. And so we need to be protecting children against those environmental risks. It doesn't mean you stop them doing anything. And most children that I have with epilepsy, they can run and play normally, but they shouldn't climb trees. They shouldn't ride a bike unless they're, supported and free of seizures. And they shouldn't swim alone. Never ever swim alone, or be in the water alone. That should never happen to a child with epilepsy. I mean, some types of epilepsy syndromes, I mentioned these more benign types, benign rolandic epilepsy or absence seizures, that they tend not to have an increased risk of mortality, and a part of that is that their seizures are generally easy to control, and often they grow out of their seizures. There is a condition called SUDEP, which is sudden unexpected death in epilepsy, and a number of children with epilepsy will for suddenly with unexpected have an arrest at night, sometimes usually in their sleep, but they're children that more typically have difficult to control epilepsy, and they're usually children who I would say their epilepsy is not in remission. And so we should work quite hard to try to get their children's seizures under control, because then they're much less risk of sudden unexpected death in epilepsy. This is called so-called SUDEP, which is a bit more common in children, especially if they have a known, what I would say, structural cause of epilepsy, like if they've had a post-meningitis, or if they've got TB, or they've got a congenital brain abnormality, or they've had a stroke. They're more at risk of sudden unexpected death in epilepsy. It can scare parents, and so I generally don't tell parents too much about sudden unexpected death in epilepsy. I try to explain to them more about how to look after their children well, how to avoid them doing dangerous things, and be with them as much as they can. Parents are often very fearful of how to look after their children with epilepsy, and they really do need a paediatrician or a doctor who knows them well and can guide them to look after their child well. I sent around this paper when I sent the reminder for this meeting, and I think this is a very good study to read. If you haven't read it, then this was Dr. Kaspari Amon from Goroka, her Masters of Medicine research, and it got published in Archives of Disease of Childhood. It's an excellent study. It's the first ever study in Papua New Guinea or in the Pacific that's looked at children with epilepsy, and Kaspari followed 47 children over 18 months, so a year and a half, and understood a lot about them. And I've just put some of the important points here, that over half of them had some developmental disability. So comorbidities were very common. Only about a quarter of them attended school. And this was also something, seen in other countries too, is that many children with epilepsy don't have an opportunity to go to school. And so that's because parents are scared about them, and because they've got not well-controlled seizures. But we should do everything we can to try to control their seizures and try to encourage their parents to send them to school if they can. In these children, injuries were very common, and burns were quite common too. It's been shown elsewhere. And most of these children were on Phenobarbitone monotherapy, and many over that 18-month period when Dr. Kaspari Amon was looking after them, many had better control with adjustments in their medication doses or changes in their treatment, and with education and better monitoring. So I think if we do manage children and get to know their families and the strengths and the vulnerabilities of their families, we can make a difference to their lives if we follow these children long term. All children with epilepsy, this was something else that was Kasparia tried to do, was to have an individualized management plan. And I think we should for all children with epilepsy, they should have a management plan that is written down and that outlines for other people who are coming in contact with them. They won't always see the same doctor every time. They'll often see different doctors or nurses. And I think you can write down some basic things about a child's epilepsy and give it to families and try to educate them. And that includes the type of epilepsy, if it's known, and how often they have their seizures, whether they have other comorbidities like blindness or hearing deficit or motor disorders, or and you can write down what their baseline treatment is and what to do if a child has ongoing seizures or an extra seizure. So there are some things that you can write down for the benefit of the parents, and some things you can write down on the management plan for the benefit of other doctors who might see the child. So I think this is really important for children with epilepsy, that they should have an individualized management plan. And you can change it over time, but it can really, I find it very helpful. The parents bring back the management plan and you just discuss it, and you might change their medications or increase the dose as the child grows. And that can really help the parents, and it can help the doctors who are looking after the child. You should try to talk to families about what their goals are, because we all have goals for our children. And I think it's important that families have some sort of goals for their child. So I discuss with them, what the goals are. And often it's like to be free of seizures, not to have seizures anymore. Sometimes it's about, I'm discussing about education, about patient, about safety, physical safety, often about safety around water or fire or bicycles, riding a bike or climbing trees. You have to just explain that to them. I've been surprised how often children can have epilepsy for many years and nobody's sat down and discussed the issues about water safety with families. And every year I see 2 or 3 children drown with epilepsy, and it's a tragedy because nobody's discussed with the family how to monitor their child around water. I always try to encourage parents to send their children to school, and many children with epilepsy, it's a good social outlet for them, so it's important that they go to school. Oral hygiene is very important for these children. So because of this gum hypertrophy that you get with anti-epileptic drugs, so I always make sure that the children are cleaning their teeth well. If you can, give them vitamin D supplements, because otherwise with their anti-epileptic drugs, they'll often have brittle bones. And some of the anti-epileptic drugs cause folic acid depletion, right? That's what they call vitamin D depletion, and also folic acid depletion. So I usually make sure they're on FeFol, or they're having a diet that's rich in folic acid. I try to explain a lot to the children as they grow older, tell them about their epilepsy and help them understand it. I think that from an early age, children can understand about their chronic condition, their epilepsy, whatever their chronic condition is, and that can help them manage it better. I mean, some children I look after remind their parents that they've got to take their medications. So I think by educating the child and educating the family, these children have a better outcome. Dr. Kasparia Mond showed that stigma was a very important factor in these parents' lives and these families' lives, and they really feared the stigma of epilepsy. And to reduce stigma, I think it's important to emphasize the positive things, that 70% of children can be seizure-free on treatment. It doesn't mean they'll be seizure-free in a week or 2 weeks, but if you just keep working at it over a period of weeks or months, then usually 70% of children can be seizure free, and they can go to school and they can live happy and productive lives. It's not contagious. Sometimes people think it's contagious, or the patients are mad or possessed by evil spirits. These are things that are common myths or misconceptions in the community. And in some families and some communities, children with epilepsy are sort of hidden away because they're considered to be possessed, or they're, considered they're psychiatrically unwell. But it's important that the families are, treat them as much as possible like any other normal child. I always think that I try to start for a child with epilepsy to be looked after properly, they need to have their whole community educated. And you can start with the child and the family, and then you widen that to the school and other people in the family. So there is a need for reducing stigma about epilepsy, and that can only come if we start treating it better and have better outcomes, I think, for children with epilepsy. All right, well, I know there was a lot of talking today. I'm sorry about that, but I wanted to just explain some fundamental things about epilepsy, and so that you know these things, because we all look after children who've got epilepsy. All right, I'm gonna turn this off now, and